Hello dear students, today we are going to learn a clinical vignette on Crohn's disease. A 24-year-old female presents to the gastroenterology clinic with a 4-month history of crampy right lower quadrant abdominal pain and frequent non-bloody diarrhea. She reports losing 12 pounds, that is 5.4 kg, unintentionally during this period and feeling generally fatigued. She also mentions a painful recurrent sore near her anus that occasionally drains yellowish fluid. Her medical history is unremarkable, but she admits to smoking a pack of cigarettes a day for past 5 years. On physical examination, her temperature is 100 degrees Fahrenheit. Abdominal examination reveals tenderness and a palpable fullness in the right lower quadrant. Inspection of the perianal area shows draining fistula. So this is a case in which a 24-year-old woman presents with crampy right lower quadrant abdominal pain, frequent diarrhea, weight loss and fatigue for over last 4 months. Right lower quadrant pain suggests the involvement of terminal ileum, which is one of the commonest sites affected in the Crohn's disease. And the diarrhea is often non-bloody when the disease predominantly involves the small intestine only. However, in cases of colonic Crohn's disease, bloody diarrhea can also occur. The most specific clue in this vignette is the recurrent draining perianal fistula. Because Crohn's disease produces transmural inflammation, that means it involves all the layers of the intestine, and that deep inflammation can form the sinus tract, fistula formation, abscess formation, and stricture formation. So, presence of perianal fistula strongly favors the Crohn's disease over the other colonic diseases like ulcerative colitis. The low-grade fever, palpable right lower quadrant fullness, and investigation shows the presence of mild leukocytosis, elevated CRP, and these all indicates the presence of active inflammation in the body. And hemoglobin is 10.5, that means there is anemia. It may be resulted from the chronic inflammation, iron deficiency, presence of occult intestinal blood loss, or chronic malabsorption. The presence of ASCA positive and P-ANCA negative antibody pattern is classically associated with the Crohn's disease. So ASCA is the anti-Saccharomyces cerevisiae antibody. However, you should remember that these antibodies are supportive rather than diagnostic, and diagnosis is established only through the combination of clinical features, endoscopy, and imaging, followed by histopathological examination of the biopsy. Smoking is a risk factor, and unlike the ulcerative colitis in which the smoking is protective, the active smoking worsens the Crohn's disease. So it increases the recurrence and is also associated with the more aggressive disease course. Now let's see the colonoscopic image and biopsy of the intestinal mucosa. The deep longitudinal and transverse ulceration separate islands of relatively preserved mucosa. So this is the preserved mucosa, and in between you can find the ulcers, and the mucosa is well preserved, separated by the ulcers, and this appearance give the cobblestone appearance. And the lesions we can see are not involving whole of the mucosa, and this pattern of involvement is known as skip lesion formation. On the biopsy image, we can see the ill-defined granuloma formation in the center, and this ill-defined non-caseating granuloma composed of the epithelioid cells, lymphocytes and plasma cells, and sometimes you can find few giant cells also. So this can be seen in the biopsy of the Crohn's disease. Now coming to the MCQs. The macroscopic and microscopic finding shown in the image are highly characteristic of a disease process driven primarily by which of the following immune mechanisms? Option A, Th2 mediated mucosal inflammation. Option B, Th1 and Th17 mediated transmural inflammation. Option C, IgE mediated mast cell degranulation. Option D, autoantibodies against the hemidesmosomes. Option E, defective chloride channel transport. The correct answer is B, the Th1 and Th17 mediated transmural inflammation. Because in Crohn's disease, the inflammation results from the inappropriate activation of the immune system against the intestinal microbial antigens, especially in genetically susceptible individuals, and it leads to the activation of the naive T cells to form the T helper 1 and T helper 17 cells in the presence of interleukin 12 and interleukin 23. Then these cells produce interferon gamma, which recruits the macrophages, and these macrophages then release the tumor necrosis factor alpha, interleukin 1 and interleukin 6, and this leads to the formation of chronic inflammation, granuloma, and Th17 cells release interleukin 17, interleukin 22, and these helps in the recruitment of the neutrophils and damages the intestinal epithelial barrier, further aggravates the inflammation, and these combined activity of Th1 cell and Th17 cell along with the macrophages and neutrophils produce chronic intestinal injury, and this chronic intestinal injury involve all the layers of the intestine from mucosa, submucosa, muscularis propria, and the uh, outer serosal layer. So this chronic inflammation damages all the layers of the intestine, and this is known as transmural inflammation. And this damage leads to the formation of fistulas, abscesses, and formation of strictures. Let's see the other options also. Th2 inflammation. This is seen in cases of ulcerative colitis. IgE mediated mast cell degranulation is seen in cases of allergies or anaphylaxis. Autoantibodies against hemidesmosome produce the bullous pemphigoid. So this is bullous pemphigoid, and option E, defective chloride channel transport. This is seen in cases of the cystic fibrosis. Now coming to the next MCQ. Based on the patient's presentation and likely diagnosis, she is at increased risk of developing which of the following types of kidney stones? So the correct answer is calcium oxalate stones. Option A is correct. Because the diseases of terminal ileum causes malabsorption of the bile salts, and these unabsorbed bile salts then enter into the colon and contribute to the diarrhea and fat malabsorption. Normally, the calcium in the intestinal lumen binds oxalate and prevents oxalate absorption. In fat malabsorption, calcium preferentially binds with the unabsorbed fatty acids only, and this leads to the free oxalate available for the absorption in the colon, and more oxalate circulates in the blood, and then it gets excreted through the urine, and this leads to the hyperoxaluria, where the stones combine with the calcium and form the calcium oxalate stones in the kidney. So this is a very important concept, how the calcium oxalate stones are formed in the Crohn's disease. Now coming to the next MCQ. The patient asks if she should quit smoking. Which of the following is the most accurate advice regarding her specific GI condition? Option A. Smoking has a protective effect and may reduce the frequency of flares. Option B. Smoking significantly increases the risk of disease exacerbation and need for surgery. Option C. Smoking only affects the risk of colorectal cancer, not the underlying inflammation. Option D. Smoking decreases the efficacy of aminosalicylates, which is the treatment for Crohn's disease, but has no other effect. Option E. Smoking cessation is recommended for cardiovascular health but not for the disease. So, we have already discussed that in cases of Crohn's disease, smoking increases the inflammatory response and it leads to the increased transmural inflammation, increased risk of a stricture, which leads to the increased likelihood of undergoing surgery. So, for Crohn's disease, smoking is bad, and for ulcerative disease, it has some protective effect. So, option B is the correct option. Now, come to the next MCQ. If a barium swallow with a small bowel follow through were performed, what classic radiological sign would most likely to be observed in her terminal ileum? Option A. Lead pipe appearance. Option B. Apple core lesion. Option C. String sign. Option D. Bird's beak sign. Option E. Corkscrew esophagus. Correct option is the option C. The string sign. Because the chronic transmural inflammation in the terminal ileum causes edema, fibrosis, and luminal narrowing. Bowel contrast study, only a thin stream of contrast passes through the narrowed segment can be seen, and this creates the string sign of Cantor. And the lead pipe appearance, which is the option A, it occurs in chronic ulcerative colitis. Apple core sign, this is seen in cases of colorectal carcinoma. Bird's beak sign is a classic sign of achalasia, and it also seen in cases of sigmoid volvulus. Option E, the corkscrew esophagus, is classical sign of diffuse esophageal spasm. So the option C, the string sign of Cantor, is the correct answer for Crohn's disease. Now come to the next MCQ. What is the mechanism of action of the most appropriate biologic therapy, for example, infliximab, used to maintain the remission in moderate to severe cases of this disease? Biological therapies for Crohn's disease include the anti-TNF alpha antibodies like infliximab and adalimumab. These bind with the soluble as well as membrane bound TNF alpha, which leads to the reduced recruitment of the macrophages and neutrophils towards the site of inflammation. And these are very helpful for the moderate to severe Crohn's disease, especially in the fistulating disease, such as in our case. Option Other biologics used for the management of Crohn's disease are the vedolizumab and natalizumab. Natalizumab acts by binding with the alpha 4 integrin subunit of the uh, integrin, and this leads to the reduced trafficking of the leukocytes towards the intestine, but it is rarely used now because of the complication which is known as progressive multifocal leukoencephalopathy. Other option is the vedolizumab. Vedolizumab binds with the alpha 4 beta 7 unit of the integrin. It reduces the recruitment of the lymphocytes towards the gut and reduce the inflammation. The JAK2 inhibitor, which is used in the management of the Crohn's disease, is the upadacitinib, and it is used for the moderate to severe cases of Crohn's disease. Next biological therapy used in the management of Crohn's disease is the ustekinumab. It is the monoclonal antibody directed against the interleukin 12 and 23, and it reduces the conversion of naive T cell to the Th1 and Th17. So it is also used in the management of Crohn's disease, especially in the anti-TNF refractory Crohn's disease cases. And the option D, which is the anti-CD20 antibody, which is the rituximab, it is not used in the management of Crohn's disease because Crohn's disease is mediated by the T cells, so it is not the right choice for the management of the Crohn's disease. However, the question have asked about the infliximab, so the correct option is the option B. Now, what are the take-home messages? Crohn's disease commonly involves the terminal ileum, and it leads to the presentation with the right lower quadrant abdominal pain, with diarrhea, weight loss, perianal fistula formation also common, and because it involves the any part of the intestine from mouth to the anus, and it not involves the all the uh, all the parts completely, so it forms the skip lesions, and this in however this skip lesions are and and it leads to the formation of the non-caseating granulomas along with the transmural inflammation involving all the layers of the intestine. The normal mucosa in between the inflamed mucosa, it produces a cobblestone appearance of the mucosa, and it also produces the creeping fat and it is one of the hallmark of the gross pathological examination in Crohn's disease. It refers to the extension of the mesenteric adipose tissue around the outer surface of the intestine, where the fat appears as to creep or wrap around the bowel wall. Normally, the mesenteric fat is attached only along the mesenteric border of the intestine, but in Crohn's disease, this fat progressively extends circumferentially and may cover more than 50% of the bowel circumference. So, creeping fat is the very important diagnostic clue on cross examination of the colon. Now, what are the complications? Terminal ileitis leads to the bile acid wasting, causing the fat malabsorption and calcium oxalate kidney stones. You can also find the stricture formation. You can see the string sign on barium swallow due to the stricture of the terminal ileum, in contrast to the lead pipe colon of the ulcerative colitis. Lifestyle modification which is required to reduce the inflammation is the prevention of smoking, because smoking strictly worsens the Crohn's. So that is all for today. Thank you.